ये वाला रिमोट ले लो। आपसे कर ले वो रिमोट नहीं होगा।
Good evening, everyone. I hope I am audible as well as visible.
Loud and clear.
Okay. So a very warm welcome to all of you and welcome to our 5th COVID update by API Noida Chapter. Since we started the first COVID update, by that time medications were very minimal. But now we have moved to an era where we have multiple antivirals, multiple immunomodulators, plasma therapy, ECMO, and so many newer therapy which have evolved in the treatment of COVID infection. And today we have an expert panel of very trained and expert people who've been treating COVID-19 patients actively. So very warm welcome to all of our speakers. We have with us Dr Anand Arora, who is joining us from UK, Birmingham. He's been an anesthetist and intensivist actively involved in the treatment of COVID patients. He's setting up protocols for treatment of these patients. And he has a vast experience regarding these patients, how to manage these patients. So it's great to have you, Dr. Anand Arora, and thank you for joining in at a short notice.
It's a pleasure. If I can do anything to help, because I've got roots in India, it will be a pleasure.
It's a pleasure to have you. We have with us Dr. Ashish Jain, who is an Associate Director, Pulmonology at Max Saket, Max Noida, and been practicing at Noida. So he has been actively involved in the treatment of COVID patients. He's a pulmonologist and an intervention bronchoscopist. So a very warm welcome to you, Dr. Ashish Jain.
Thank you. Thank you very much.
And we have with us an intensivist and anesthetist, Dr. Deven Juneja, who has been treating COVID patients at Max Saket. He is also an associate director intensivist at Max Saket. So he has, to his credibility and intense experience of treating COVID patients. So a very warm welcome to you, Dr. Deven Juneja.
Thank you, ma'am. It's a pleasure to be here today.
Thank you, Dr. Deven. And we will start with the meeting. And a very warm welcome to all those people who have joined in at this time when they are busy running their OPDs. A very warm welcome to all of you. So we will start with Dr. Ashish first because he was involved in a bronchoscopy case and I had to actually drag him out. Dr. Ashish, there have been many antivirals which are available these days. We started with Tocilizumab and then Favipiravir and Remdesivir, which is available. So without wasting much time, I just want to know that which antivirals are to be started in mild cases, which antiviral in moderate to severe cases, and when do people of COVID need antiviral treatment, if at all? Dr. Ashish Jain, please. Ashish, please unmute. Please unmute yourself, Dr. Ashish.
Thank you very much, Dr. Meenakshi, for inviting me here. And I send my greetings to Dr. Arora as well. Thank you very much for being here. The only unfortunate thing is that, as Dr. Meenakshi said, that I have to rush because of some unexpected emergency right now, but I'll be here only for 5-7 minutes. No problem. As regards to the antiviral, what is happening is that the information is trickling in slowly and gradually, and this is a new disease that we are treating, and both the things are happening at the same time. There is a scarcity of some information, and then there is a flooding of the rest of the other information. As of today, what we know about the antivirals is that the Tocilizumab is not being used in this particular season, that is in this COVID-19. The Tocilizumab is not being used. What we have are the different nucleoside analog which inhibits the viral RNA polymerase and prevents the viral replication. are these Remdesivir as well as the Favipiravir. So these are the two medications that we are using. Now, it is always known that in these viral illnesses, it is always better to start these antiviral drugs early in the course of the illness, because what happens is that this viral illnesses, they are self-limiting, but they induce a cytokine storm. The body's immune mechanism, it takes place, and there is a violent reaction of that, and that leads to the further problems, and that is the cause for the patients going onto the ventilator and causing a mortality. So to prevent that, it is better that we start these medications early. Now, how early? Because most of these patients, they do not even need certain medications, and the body immunity is capable of taking it over. So usually what we are doing in our practice and what has been seeing is, start these medications, both these Favipiravir as well as Remdesivir. Whenever the patient has got some lung involvement, whenever the patient's oxygen requirement increases, or whenever the oxygen saturation falls down, or the patient becomes breathless. In these symptomatic patients, if we start these medications at that point of time, they are reasonably effective. There are certain studies which shows that, after day 4, there is 65% of the Russian study basically. The 65% of them become negative, and even 90% on day 10. But if you delay them further, then you may be able to prevent viral replication to a certain extent, but then the cytokine storm and the body's immunological response, violent response, it takes over, and that is responsible for killing the patient or a high morbidity of the patient. आप unmute कीजिए, please unmute.
Which patient for Favipiravir, and which patient for Remdesivir, and which patient for Liponavir ritonavir combination?
So what we are using right now is Favipiravir as well as the Remdesivir. These are the two medications that we are using. In less severe cases, in early disease, when you start having this, oxygen saturation going down in the patients who are otherwise healthy with less of comorbidity illness, not very elderly, we are starting with this Favipiravir, but the elderly patients and those who are having, high comorbidities, or when the oxygen saturation drops significantly, or those who are requiring ICUs, these patients are on the Remdesivir. But we have hardly switched over from one to the other.
Okay, so you recommend that all our patients, we start them on Favipiravir first day, and
At least,
if need be, and if they are not responding, if they are deteriorating, then use Remdesivir?
No, this is not what we are doing right now. We are starting, on the day of the presentation, we decide that whether you need this or not. On the day of admission, most of the patients are asymptomatic, but if as I said that, if they are not having too many comorbidities, if there is a mild illness and, fever is probably there, but the oxygen is not dropping too fast, or if, then we are starting this Favipiravir. But if there is a violent crash like situation, if the oxygen saturation drops down significantly, or if there are too many comorbidities and lung infiltrates and the patient is requiring ICU, these are the patients, those who are going on the Remdesivir thing.
Okay, do you recommend starting antivirals in a very mild cases who are at home? Mildly symptomatic cases?
No, not at home. Not at home. If the oxygen saturation is not dropping, then we are not starting these antiviral. It is only when the oxygen saturation starts dropping, or else if the patient is under a critical stage, is suffering from some other lung problem, diabetes, or hypertension, or renal failure, heart issues, and the patient is very precarious in any case to start with, that is the time that I would start him on antiviral.
Okay, so no Favipiravir for OPD patients. That's what you're saying.
No, I would not recommend this unless the patient is able to maintain the oxygen saturation.
Okay, because there is a lot of over-the-counter selling of this drug which is happening, and most of our patients are pressing on us to write Favipiravir, which is not probably needed for mild cases who are maintaining saturations.
So there is a lot of panic in the society. There is a lot of panic in the society, and I too face a lot of pressure from the patients of prescribing. But as of now, I'm not prescribing for all the asymptomatic patients. The patients who start complaining of breathlessness or drop in oxygen saturation, these are the patients, those who go on to the onto the antiviral.
Okay, and there is no such contraindication to this antivirals. I think Favipiravir is relatively safe drug.
It is relatively safe, even in the renal thing. It is relatively safe. There are some issues with the transaminases. If they are raised more than 3 times, then probably you can avoid this. But otherwise, these are relatively safe drugs.
And same way with Remdesivir.
The only thing with Favipiravir is the pill burden. You know, there are a lot of medications that that you have to consume.
Okay. What about Remdesivir? What is the exact indication for giving Remdesivir? Because most of the ICUs are giving Remdesivir now left and right since it started being available in India. So what are actual
I would suggest that if there is a severe illness to start with, if the comorbidities are very high, if the oxygen saturation is dropping significantly, and or the oxygen requirement is scaling up, that is the time that I would start the patients on Remdesivir.
Okay, thank you so much. Any other antivirals you recommend?
As of now, these are the 2 things that we are practicing.
Okay. Thank you, Dr. Ashish.
Dr. Ashish,
Dr.
Ashish, can I ask you one question? There are a few questions in the chat. One question is: patient at home getting breathless on walking. Should we start it on antivirals?
So if the patient is getting breathless, we actually the breathlessness is coming late in this disease. The oxygen, they say breathlessness. Maybe this is an exacerbation of asthma or something else. What I am asking the patients is that not only they check their SpO2 on room air sitting down, but I also ask them to do a 6-minute walk and then test the SpO2, because by this way we can uncover the hypoxia. So breathlessness, I am not too sure whether I will start, but hypoxia definitely.
But then these patients should ideally be admitted, not at home, right?
Sorry?
Then if the patient is developing hypoxia or breathlessness on walking, then these patients should ideally be admitted rather than at home.
No, your voice is not clear. I'm sorry.
So what he is saying is that then these patients should ideally be in the hospital. They should be admitted.
If the patient is breathless, if the comorbid illness, also increases, then definitely patient should be in the hospital.
So not mild cases need administration of antivirals.
Yeah.
Thank you, Dr. Ashish.
Sir, what is the experience with Tocilizumab?
Dr. Anand, what is your experience on antiviral? When do you recommend antivirals to be used?
Sorry?
When do you recommend that antivirals be used? And which antiviral?
It's come to me now, is that right? Yeah.
So
we
have... very much. I will have to leave. Thank you.
Okay. Thank you, Dr. Ashish, for joining in. Thank you. Thank you. Dr. Anand.
Yes. Can we first mute? Can we first mute the people who are actually not speaking? But echo. Thank you. Only antiviral that we use in the UK is Remdesivir, and the reason why we use it is, as Dr. Jain is, Ashish has very clearly said, Ashish Jain. So he's actually beautifully conveyed what we want to. So the virus actually causes initial response, and then most of the disease process is secondary to the host responding abnormally to this virus. So the idea is that anybody who's dropping their saturations and therefore is in hospital, once they are either confirmed or suspected COVID, we would start Remdesivir, and the dose would be 200 milligrams once and then 100 milligrams. There is some discrepancy with regards to whether you use it for 10 days or 5. If the patient's getting much better, then you know that their host response is reasonable. They're not going to get a cytokine storm, and it might be reasonable if they're getting asymptomatic within 5 days to stop it. However, if somebody is very ill, on intensive care, requiring CPAP or intubated, then the current recommendation is using it for the full 10 days. Having said all that, there is no randomized controlled trial yet. The evidence is still lacking, but because the disease is moving so fast, I do not think that the lack of a randomized controlled trial is a reason to stop not using it. There is some evidence from prospective studies that it actually reduces the number of days on ITU and also reduces mortality.
Thank you, Dr. Anand. In India, we've been using a lot of HCQS for treatment of COVID patients, and they recommend HCQS should not be used with Remdesivir. So what is your take on that? Should we not use HCQS when we are using HCQS?
We don't use hydroxychloroquine or chloroquine at all. As you're aware, with Amitabh, there have been a lot of discussions on the Maulana Azad forum. Yeah. And there is, to my mind, no evidence that hydroxychloroquine benefits either for prophylaxis or treatment. However, I know that there is a very strong body of opinion in India and they want to continue to use it. I really have zero experience of it, and I won't want, other than quoting studies, I will not say anything about it.
Okay, what about Favipiravir? Are you using it in UK?
No, just Remdesivir.
Just Remdesivir.
That's all. Yeah, okay. That's right.
And how soon do you initiate? Do you initiate them on mild cases also, or only on moderate and severe cases?
Okay, so now the definition of the mild and the moderate to severe cases would be different in India compared to here. The difference is because most of the patients who are not hypoxic are not admitted to the hospital. I know it is different in India, where people get admitted even if they've got higher saturations. That would be a combination of government policy as well as people getting anxious and therefore the ability to admit themselves if they wish to get admitted. Yeah. The policy in the UK is that if your saturations are more than 96% without requirement for oxygen therapy, then as long as you're not breathless, you stay at home and there is no supportive care required other than eating and drinking and isolating yourself.
Okay. Okay.
So we would call those patients mildly symptomatic.
Okay. So mildly symptomatic patient may not require antivirals.
They don't get anything at all because as Dr. Jain has beautifully explained, what are we trying to do? We are trying to make sure that the virus does not basically trigger a dramatic host response. That's all we are trying to do. So if you think of that as the principle, then somebody is already either asymptomatic or mildly symptomatic means that their immune system is either able to cope with the virus, which you'd expect in more than 90% of the patients anyway, or is not producing the cytokine storm and the other things that lead to further development of ARDS. So there is no need for an antiviral there, just like for the flu, oseltamivir is supposed to, there's two different ways of approaching it, but people say the patient will get better in 7 days or 1 week, depending on whether you use it or not.
So you very rightly and beautifully said that Remdesivir has got scientific data to say that if we use Remdesivir, then the morbidity and the virus replication time and the duration of illness does reduce. So since we've started getting Remdesivir in India, so we've started using it. So what should we be cautious about? Because they say if the LFTs and KFTs are quite deranged, we should not use it. So what are the things we should keep in mind while we are using Remdesivir?
Yeah. So with Remdesivir, you do not need to worry too much about the renal excretion. So the renal function is less important. With LFTs, there is a mild rise in AST and ALT. So unless somebody's got cirrhosis, for example, in the vast majority of patients, there aren't that many contraindications, including in the recovery trial, which is where we're using it in the form of a randomized control trial.
Okay, all right. So I think that's the only antiviral you are using.
That's
Are you
correct.
using ivermectin? Are you using
No,
nitrosoxamide?
all of that is Indian.
Okay, so you've been using for parasite killing, for the viral killing, just the antiviral remdesivir. That's the
Correct.
only thing which you're
That's
using.
right.
Okay, that's right. Okay, and what about lopinavir ritonavir combination? Does it have any study, or is it?
There are studies and they did not show an improvement, and therefore we are not using it.
Okay. All right. So I think that makes it clear about antiviral drugs.
Yeah.
So since you are an intensivist and anesthetist and invasively doing ventilation also, so what all can we do to prevent a patient from going on tubes? Because we know once patients are intubated, the chances of mortality high and the chances of recovery decrease. So what all
Okay.
can we do before that, so that can we put the patient non-invasive, or
Yeah.
what all
So
can be done to
yeah.
prevent that?
So this is the crux of the matter here, and that is why I'd accepted your invitation to come in and, share whatever we've learned. Um, um, Initially, we did not have the evidence because we did not have the help like I'm trying to give to you in India. And our information was gleaned from the Chinese, whose communication was not the best, and I don't think they were very well organized either. And the Italians, maybe because of language barriers and whatever else, effectively we were blind. And the information coming out was intubate early. That we did for the first couple of weeks and found to our chagrin that people were not getting better and they were dying left, right, and center. What we know now is that we should try and reduce the incidence of intubation as far as possible, not at the expense of not intubating anybody even when they're developing a multiple organ failure. However, there are multiple things that we can do before we reach the stage where somebody needs to be intubated. So starting from the simplest, when a patient comes into the hospital, and if their saturations are low being defined as less than 96, and we are talking about the non-COAD cohort, then oxygen therapy is the first port of call. The SATs aim should be 92 to 96%. If the requirement for maintaining those SATs, when the FiO2 requirement goes to more than 40%, then next steps need to be taken. So the target for referral to an intensive care unit is SATs of less than 92, or in a COPD cohort less than 88, with the FiO2 requirement of more than 40%. We call it 0.4 here. So 40% oxygen requirement and a respiratory rate of more than 30 and SATs of less than 92 is a requirement for referral to ITU. A referral to ITU does not mean automatic admission to ITU. It just creates a sort of register where we know which patients might deteriorate. Next step is what we call awake proning. So the patient needs to be conscious and alert and able to do this. This is a very low-tech intervention that has had a dramatic effect in reducing the number of patients requiring intubation or further non-invasive respiratory therapy. This can be done at home as well if required. The reason why I'm not saying so is because that might delay a patient coming into hospital. However, as we all know, proning improves VQ mismatch and is able to improve your PO2, which is the main problem in these patients. So proning for 3 to 4 hours at a time, using an appropriate system where the belly is free. So it can't be used for the very obese patients. And we need to have pillows under the chest as well as pelvis. If you want, afterwards, I can send you a pictorial representation that we've done a protocol for. The point is the patient needs to be prone 3 to 4 hours and then supine again for an hour or so that they can go to the toilet, eat and drink, and then go prone again. The aim is 16 to 18 hours of being prone in every 24-hour period, because sometimes proning can take some time for the VQ mismatch to improve. This can also be done while oxygen is on, and this intervention itself has led to many patients not requiring intensive care. If this intervention does not help, the next step is using non-invasive ventilation, which encompasses two different things. Those two different things are continuous positive airway pressure, also called CPAP, and non-invasive ventilation, which means giving two levels. It's also called bi-level ventilation, depending on what you understand with NIV. So this is primarily a disease where oxygenation is hampered, and therefore CPAP is the modality which is used most commonly. If COVID happens to a patient who's already got COPD, for example, then you might need non-invasive ventilation as well. However, the vast majority of patients, if you're talking about people with normal lungs, CPAP would suffice. We start with 10 centimeters of water PEEP. We need to use a unvented or a non-vented mask or hood, because otherwise there'll be a huge generation of aerosol. With a non-vented mask or a non-vented hood, with the expiratory port having a viral or a microbiological filter, there is less/no risk of aerosol generation. However, this therapy should only be done in an area where the healthcare providers are wearing FFP3 or N95 mask, because there is a possibility of the face mask coming loose, or the patient coughing and whatever else and aerosolizing. So of high flow nasal oxygen, that is not something that we would recommend, because there is a possibility that your hospital's oxygen supplies will be overwhelmed. It requires 40 liters of oxygen mixed air and per patient, and depending on your caseload, you might find that you're not able to meet the oxygen requirements. I'll stop there for a second in case there's questions, because I know that there's a limited amount of time that we need to talk about.
First thing is, what is the role of high flow nasal oxygen? We've been using a lot of HFNO here. So what is your experience with that?
So my experience with high flow nasal oxygen is that it can be helpful, especially in the slightly less severely ill patients. The only thing you need to consider with high flow nasal oxygen would be that it is a slightly milder form of CPAP. And for high flow nasal oxygen, unless you use higher flows of more than 40 liters per minute air, oxygen enriched air, you are unlikely to provide much of CPAP effect. So if you want to use it appropriately, you'll need to use a higher flow rate. If your hospital's oxygen supplies allow it, it is a legitimate modality to use and can be effective. However, you might need to move on to CPAP for those who are not benefiting from it. Equally, some people are not able to tolerate the tight CPAP masks and hoods, and for them, high flow nasal oxygen works well.
Yeah, at BACS, we are using a lot of high flow nasal oxygen. A lot of patients are being treated on HFNO, and we found good results. So the learning is that we can delay intubation as much as possible and try non-invasive ventilation. The concept which has changed over time.
The reason why we are trying to, the reason why we are trying to reduce intubation is because, number one, with intubation, you have to give sedation, and that interferes with your immune modulation and the body's response to the virus, because sedation is known to do that. Number two, there's a greater chance of a ventilator-associated pneumonia. And number three, once somebody is on a ventilator, there is a very high, the airway pressures are higher, and therefore the chances of multi-organ failure also increase. The death rate at the moment for intubated patients with the improved modalities that we are using now is about 36-37%. Whereas people who are not intubated and ventilated, the death rate is much lesser, at in the region of about 20% if they are on CPAP.
So there are a few questions in the chat box. Will NIV be more risky for healthcare worker? Can it be avoided? I think you have answered that, but you can carry it on.
Okay, we'll talk about dexamethasone later because you're going to, I know that that's one of our topics. With regards to NIV use and the risk to healthcare workers, as I said, we need to use a non-vented or an unvented mask or hood. If you Google British Thoracic Society NIV guidance for COVID, it is the first thing that comes up with a beautiful picture as well, which shows you what I mean by a non-vented mask. Effectively, what we're trying to say is that we don't want an expiratory port which is open without a filter. So the expiratory port needs to have a filter. Once you've applied a filter, then the chances of aerosol generation, which are a risk to healthcare workers, are close to zero. And there is another school of thought which says that if you accidentally disconnect the inspiratory limb, what is being generated and spewed into the atmosphere is what's coming out of the ventilator, not from the patient. What is coming out of the ventilator is actually not make the patient's secretions, and therefore is unlikely to be aerosol generating. I think that answers that question with regards to whether it is a healthcare risk. However, anywhere we only use CPAP and NIV in areas which are with healthcare workers wearing FFP3 masks, which is the equivalent of your N95.
There's another question, should nebulization be avoided?
Okay, we initially avoided nebulization. However, the same principle applies, that nebulization is using clean air or oxygen applied to a nebulizer. The other thing is, if it is used with a normal Hudson mask, a plastic mask, then there is only 1 or 2 studies which were done much before COVID, which actually looked at what happens with the nebulized gases. So they've done UV light on the droplets and seen that if you're doing it through a face mask, it only goes forward till about 40 centimeters and then settles. So again, I wouldn't do it in an area where healthcare workers are not wearing a FFP3 or N95, but if they're wearing it, then nebulization should be allowed, which is what we've done now.
We've also been practicing nebulization at Max Healthcare, and we've been nebulizing our patient regularly.
Absolutely.
And again, what you said is non-invasive ventilation till there is a heartless need to intubate. So thank you, Dr. Arora, but I want you to be staying on. We are moving on to the, we'll come back to you. So I would invite Dr. Deven. Dr. Deven, are you there?
Yeah, I'm here.
Okay. So as we know, it's about, first thing we talked about virals, antivirals. So it's about killing the virus. It's about ventilating. And most important thing is there's a lot of cytokines which are released, and most of the patient die because of that cytokine storm. So what all can we do to reduce this cytokine storm? And what is your experience? How are you dealing with cytokine storm at Max Healthcare?
Yeah. Thank you for inviting me here. And Dr. Ashish Jain and Dr. Anand Arora have very beautifully explained all these things. So basically, if you look at the COVID response, it can be broadly divided into 3 phases. The first phase is the viral phase. So during the viral phase is the time up to 7 days when you will feel that the maximum response can be generated by using antivirals. So like Dr. Anand Arora also said that they have been using Remdesivir. Now we have got an option of using Favipiravir also, which is available in oral formulation and can be used in mild to moderate cases. Although our experience has just started on that and we have started using it in the last 1 week only, I do not see any reason why this should not be started in mild and moderate cases. See, because what we are trying to do, as Dr. Arora rightly said, that we want to reduce the viral load. So if the viral load is very, very high, then the chances of patient going from mild to moderate and moderate to severe and severe to critical stage is very, very high. And there is no way we can predict that which patient is going to go from mild to moderate and moderate to severe. So reducing viral load even if the patient got symptoms, I would rather the patient is having mild symptoms, and then also these antivirals can be initiated at home. We have been using HCQ and azithromycin combination, and we have had a good enough response. Obviously, there are certain studies and the jury is still out whether it is going to be effective or not. But now we have got Favipiravir and we have started using it. So till now, the response is okay with that also. Now, if you look at the second phase, obviously in critically ill patients here, I would like to use Remdesivir. Now comes the second phase. If the viral load is severe or the patient has got comorbidities, he might move into the next phase, which is the pulmonary phase. In this, the patient will start experiencing pulmonary complications. So to begin with, he might have signs of hypoxia. Later on, he might start feeling respiratory distress or breathlessness. So once the patient develops fever, once the patient is diagnosed to have COVID-19, what we do is we ask them to keep on checking their pulse oxygen saturation even at home. And once their saturation drops below 93%, we advise them to get admitted and start them on oxygen therapy. So during this pulmonary phase, we believe that the maximum benefit can be achieved by using steroids in the early phase. So we have got a lot of options of using steroids. Lately, the recovery trial, the results which have come from UK. So they are also showing that if you use dexamethasone, start them early, especially if the patient is on oxygen, and then you should start the patient on dexamethasone. And they have found that the mortality rate is significantly less when you use this in this particular patient subgroup. And more so, even if the patient is sick, patient is on mechanical ventilator, then also there is a significant mortality difference when you are using dexamethasone versus not using steroids at all. So mortality difference was around 11 to 12% in such patient subgroup also. So you have to use steroids, you have to start them early. The choice of steroids, we have had experience of using methylprednisolone. We have been using it for quite some time. But the dose which we were using was much higher as compared to the recovery trial. So what we were using, methylprednisolone of 1 to 2 mg per kg per day. Generally, we used to start early. Once the patient develops start requiring oxygen, at that particular point of time, we start the patient on steroid, use it for 5 days, 1 to 2 mg per kg dose, and with the use of steroid. And dexamethasone, the recovery trial which has shown, they are using a much lower dose of steroid, that is 6 mg of dexamethasone, but they have given it for a prolonged period up to 10 days. So if you look at the equivalent dose of methylprednisolone, it comes out to be only 32 mg. So the dose used in recovery trial is slightly less to that what we have been using, but the duration of therapy has been on the longer side. So when you look at the data from the previous similar viral infection, even SARS or H1N1, the steroids were not found to be very, very useful in that. Especially H1N1, it did increase mortality. So it was a relative contraindication to use steroids in such patients, even though they were developing ARDS. But in COVID-19 pneumonias, we have found to have good response with using steroids. But we have to accept that the large dose of steroids should be avoided. Prolonged use of steroids should be avoided. We should use low doses of steroid, and that too for a short period of time, especially when the patient starts requiring oxygen therapy. Other drug, now if the patient goes into the CRS, that is the cytokine release syndrome, that is the third phase. And most of the deaths occur because of the cytokine release syndrome and related complications like ARDS or multiple organ dysfunction syndrome. So if the patient is going into that category, then we have to look at the other markers also. So it is not only the clinical picture, you also have to look at the biochemical markers. And in these biochemical markers, what we are looking at is the ferritin levels and the IL-6 levels, which we are doing very routinely in all our patients in ICU. So if the IL-6 levels are on the higher side and the ferritin levels are on the higher side, you have already started steroids, patient is deteriorating, that is the time when you should think about Tocilizumab. And what we are doing is we are giving Tocilizumab in a dose of 8 mg per kg stat dose over a period of over an infusion of 1 hour, and repeating it up to a maximum of 3 doses. So most of the patients require at least 2 doses, which are set 12 hours apart. But in a few patients, we have also gone up to 3 doses. But when we are using this drug like tocilizumab, again, it is renal modification is also not required. It can also cause hepatic dysfunction. So what we are doing is we have to look for chances of secondary infection. So chances of secondary infection, if the patient is on steroids, patient has received tocilizumab, chances of secondary infections are high. Reactivation of CMV, pneumonia, we have also seen in many patients who have received 2 to 3 doses of tocilizumab. So you have to keep all these things in mind whenever you are using these drugs. And especially if you are using steroids for a longer period of time, then the chances of secondary infections are much, much higher. Ma'am, you need to unmute yourself. I cannot hear you.
Thank you, Dr. Deven, for talking about steroids and interleukin-6 inhibitors. So what we have understood from you is that steroids, if started in time and in low dosages, they may be beneficial. So steroid, either methylprednisolone, which is used in low doses, 0.1 to 1 milligram per kg per day.
1 to 2 milligram per kg per
1
day.
to 2 milligram per kg per day. Or dexamethasone 6 milligram per day, as has been shown in recovery trial, may reduce the morbidity of the patient.
Yeah, even mortality benefit can be.
Mortality. And simultaneously, we need to monitor few parameters like ferritin level and interleukin-6 level. And interleukin-6 level, if they are high and patient is deteriorating, then you could use 1 or 2 dosages or 3 dosages of tocilizumab. So what interleukin level are you looking at that beyond which we should start tocilizumab? And how do you decide whether we use 2 dosages or 3 dosages? And how do you monitor the recovery of the patient while the patient is on these interleukin-6 inhibitors?
Actually, there is no single value which has been shown for IL-6 level that this is the level at which you should start using tocilizumab. The normal range is 0 to 7. So what we are doing is, if the clinic is there, that means the patient is not showing response to drug therapy alone, and levels of more than 10 times of starting tocilizumab. So, and obviously the response, as I told you, most of the patients will require at least 2 doses. And because you do not expect rapid response even if you give tocilizumab to these patients, the response is going to happen at least after 12 to 24 hours. So in that time, you repeat a dose of tocilizumab. You keep on monitoring the IL-6 levels. We must understand that this IL-6 antagonist. So again, so IL-6 levels may still be on the higher side because it is going to just block the receptor where IL-6 is going to get attached and cause a reaction. So it is not going to reduce the level of IL-6 per se. It is going to reduce the effects of IL-6. So that is what we are trying to achieve by giving a tocilizumab. So just by monitoring the IL-6 levels, you cannot say whether the tocilizumab is working or not working. So what you have to look at is the clinical picture. So once you give tocilizumab, after 12-24 hours, you might see that the patient is showing signs of recovery, improvement in saturation levels, or improvement in the dyspnea, breathlessness, or recovery in the multi-organ dysfunction syndrome. So these are the effects which you would see. Many times we have seen once we give tocilizumab, IL-6 levels rather increase. So that is because of the disease per se, because tocilizumab is not going to reduce the IL-6 levels directly.
Okay, thank you, Dr. Deven. I will come back to you. I will ask Dr. Anand Arora, what are you doing to reduce the cytokine storm in the patient, and how are the immunomodulators being used at UK in your area?
Yeah, before I do that, because I promised that I'll show you the awake prone picture, I'll just share my screen for a second. If you wouldn't mind enabling my screen sharing. Meenakshi?
Yeah, we're sharing your screen.
Okay, while they're doing that, basically, I agree with you. I was about to, yeah, basically, as Deven has explained so clearly, the improvements with Tocilizumab is actually just clinical. So we look at PF ratios. So the PO2 to FI2 ratio normally tends to improve. And if there was multi-organ dysfunction, that will start improving. So that is what we're looking for as intensivists when we're using that. With regards to steroids, my inclination would be to use methylprednisolone. We have used methylprednisolone in a dose of 500 milligrams, which is a very high dose, but that was in a slightly different setting. It was early ARDS secondary to the cytokine storm, and this was before the recovery trial had reported the significant advantage of using dexamethasone. So we used it in 2 or 3 patients. I have to explain that in the NHS in the UK, you can't just decide I'm going to use this particular drug, because that's just not how the governance is in our hospitals here. So we used 500 milligrams of methylprednisolone, which we often tend to use as pulse therapy times 3 days. And we did get good results. So that was telling us that we do need to use steroids. The recovery trial has shown very clearly that 6 milligrams or 6.6 milligrams, which is the equivalent of 8 milligrams of dexamethasone. Dexamethasone is available here as a 8 milligram as salt or 6.6 milligrams as an ampule. So although the recovery trial says 6, but we don't use the 1.84 ml, we actually tend to use the 2 mils, which is the equivalent of 6.6 milligrams of base or 8 milligrams of salt. It's just how it is documented. I'm just saying so because in Europe, the documentation is slightly different. We used to call it 8 milligrams and it's now down to 6.6. So just for clarity, so that in India, if you're going to use the values from the recovery trial, that's the background to it. And it's actually a 2 ml, which is 4 milligrams per mil as it used to be in old money, and 3.3 milligrams per mil in new money. So that's that clarification. And if the screen share is allowed, it's still not allowed. So maybe I'll
Anand, maybe you can WhatsApp me the photograph and I'll share it with you.
Yeah, happily do that. So what I'll do is I'll just take a screenshot on my phone and send it to the organizers, and they can share it with everybody. Okay, so while they've been trying to do that, we've talked about Toci and dexamethasone. So I agree with what Dr. Juneja said, that effectively we should use low dose steroids. The only other situation where we're using steroids is, as intensivists would know, there have been multiple cases where we've not been able to extubate patients as expected. And the reason, and despite having low FiO2s and breathing normally on spontaneous on the ventilator, we extubated them, and unexpectedly they had to be reintubated. This was especially when it was early in the phase of the disease, which is day 7 or day 8 of intubation. So we've become more careful now, and the basis of that is that some of these patients seem to have airway swelling, maybe from prolonged intubation, or might be from the disease process itself. Nobody knows. So when we are anticipating extubation, we use extubation dose dexamethasone, which is 6.6 milligrams 3 times a day for 48 hours before anticipated extubation. So other than that, we just use dexamethasone 6.6 milligrams once a day for 10 days.
You can send a screenshot.
I think you can.
The screenshot, do you want it now?
Yeah.
Anand, can you screen share?
Second?
Can you share the screen? I've allowed you.
Let me try. Yes.
Dr. Anand, you have explained it very nicely. My question to you is, you are saying that intubation should be delayed. So what would be your criteria to intubate such a patient?
Yes, that's quite important. I'll talk to you about that in a second. Are you able to see my screen?
Yeah.
You can see your screen.
Okay, so just so I can clarify, this is the awake proning guidance, which is used in our hospital. And as you can see, we do it for 4-hour periods and allow 1 hour for comfort breaks. Sometimes patients are not able to follow the 4-hour routine. If they are not able to follow the 4-hour routine, they can do it for as long as possible, say, for example, 2 hours. Okay, the things that are needed to very quickly mention were, number one, you need to have some chest pillows. Most important bit is you need some free space for the abdomen, because in our prone patients, some of them who are very large, because the UK as well as the US has a problem with morbid obesity, you can actually restrict diaphragmatic movement and actually worsens the PO2 as well as the increase in CO2. So when you prone somebody, if you're doing arterial blood gases, the CO2, if it starts rising, tells you that you're not free. The easy way to check is put your hand when the patient's prone between the patient's belly and the bed, and the hand should be able to go in reasonably easily. Even if it is not completely free and hanging, you should be able to put your hand in. The other thing to remember is, as you can see, the bed should be steep head up. That also helps with diaphragmatic excursion. I just wanted that to be absolutely clear. The head can be on one side or the other, and the oxygen mask can be left in place. You can actually have CPAP or high flow nasal oxygen on as well with awake proning. And yeah, that's what I effectively wanted to say. So I'll stop screen sharing now. Okay, so now I come to Dr. Juneja's question about when do we decide to intubate. So initially, the thought process was intubate early because they were quite breathless and breathing fast. However, we've had experience with CPAP and high flow nasal oxygen now, and knowing that CPAP is associated with a death rate of in the region of about a mortality of about 20-odd%, and we are talking about sick patients. We're not talking about people who don't require CPAP. We've talked about the people who do require CPAP. So those patients can sometimes have a respiratory rate of even 45 to 50. I've seen multiple patients who've got better despite having a high respiratory rate. What we are looking for intubation is, number one, desaturation despite the oxygen therapy through CPAP. So the maximum CPAP that we apply is 15 centimeters of water. Patient has to be conscious and oriented. If they're becoming drowsy, that's an indication that CPAP's failing, because the patient's not getting enough oxygen. They could also be getting drowsy because of tiredness, which means work or breathings increase so much that they're not able to cope. That is another reason for intubation. So we don't really go by the traditional parameters. We go by oxygenation and tiredness, as in increased work or breathing. Those are the only two criteria. Respiratory rate used to be a criteria in pre-COVID times, but we don't use that anymore. And we've learned that by trial and error and experience. There can be some young people who are breathing really fast, but have managed to tide over that period where they were getting a cytokine storm or the host response, and have come out on the other side. We call that the COVID hump. So once they're over the COVID hump and their markers like CRP and white cell counts start to improve, you know that they won't require intubation and ventilation. Does that answer your question, Dr. Juneja?
Yeah, just one more thing. What oxygen levels are we talking about? Because these patients are happily hypoxic. So they are tolerating oxygen levels up to 75-80% also. They are absolutely conscious. So at what oxygen level you would feel that now is the time that we should intubate these patients?
Okay, so that is, if the SATs are 55s and 60s, that is the happy hypoxia where a patient will arrest if you try to intubate them. So I'm sorry, we don't accept that low SATs.
No,
those low SATs and, second?
I was saying 75-80%.
No, even 75-80 is not something that we'll accept. We have accepted SATs of in the region of 82-83 in some COPD patients, but we aim for SATs of more than 88%. Some people we've accepted SATs of 85 as well, but any lower than that, we would call it as failure of CPAP and the need to move to the next stage.
Yeah, Dr. Anand, that is the problem. See, we are also relying on papers coming from Europe and US. And all these papers suggest that we should delay intubation, but none of these papers suggest that at what saturation levels you should go ahead and intubate these patients.
So that's I'm telling you from experience.
Our interpretation of this data is very, very erratic. So people are accepting much lower saturation values also. And what we have seen is in these patients, a lot of fibrosis happens. So even if they will survive this COVID hump, then also there is extensive fibrosis in the lungs, and they require NIV support for a very prolonged period, and they later develop a lot of complication. We have seen a high incidence of pneumothoraxes, high incidence of secondary infection in these patients. So obviously we have to be a bit skeptical, and we have found fairly good results if we intubate young patients who are not morbidly obese, who can be prone easily. So we have intubated those patients at an earlier stage, put them in prone position, and we have been able to extubate them in a week or so time.
So what are you defining as early? See, the definition of early at the start of the disease process was, as I said to you, anybody with a respiratory rate of more than 35, requiring oxygen of more than 60%, we would intubate straight away.
Yeah.
Okay. So that is what we called early.
Early, if the patient is requiring continuous NIV support with 100% FiO2, that is, then we should go ahead and intubate these patients.
Of course you should.
Yeah.
Absolutely. 100% oxygen requirement is obviously a failure of oxygenation.
Yeah, exactly.
Thank you, Dr. Anand. There have been few more questions. There is one question from Dr. Nikunj. During home treatment, which day of illness can we be assured that severity of illness and respiratory problems won't aggravate further?
This is the $1 million question that will make a doctor a very rich man. Right. But if you look at the disease process, as was explained earlier by a panelist, there are sort of 3 phases. There's the initial phase where you're starting to get the disease, you're not really that ill. And then there is the phase where the virus is basically creating havoc. And then there is the phase where your host response is causing the havoc. So effectively, once you're after the second phase where the virus has done its bit, and if you're not that unwell, then it is very unlikely you'll get a cytokine storm, and therefore you're over the worst, is my very simplified explanation of that question.
Very right. Very rightly said. Any other immunomodulators you've been using at UK other than the interleukin-6 inhibitor Tocilizumab?
No, that's it.
So this is the only immunomodulator.
Yeah.
You have.
As I said to you, India has the advantage that if a particular center gets agreement amongst their own intensivists that they want to use a particular drug, then you can start using it if it's available. Whereas we have to go through a full clinical governance pathway, which admittedly has been made much more rapid during this pandemic, and we've altered our treatment modalities and management because the patients were dying. We were keeping them very dry initially with the ARDS net protocol, and we were giving them high pressures. So we saw that people were dying and realized that that was not right. I don't know whether the panelists know or not. I did a video at that time where it's on YouTube if you need to see it. The initial problems compared to how we changed. What we are talking now is how we've changed, and therefore our death rates are significantly lower, including intubated patients, compared to the initial parts.
So how do you see the results of Tocilizumab, and how frequently are you using them in your intensive care? Or how many percentage of patients, like out of 100 patients, how many, and do you recommend any interleukin level beyond which it should be used? How should we monitor it?
Yeah, I would completely concur with Dr. Juneja. He's explained it beautifully. That's exactly what we do as well.
That is what you've been doing as well.
Yeah.
Okay.
Yeah.
So,
and just remember that you will not see a reduction in interleukin levels after using Toci. You are going to see clinical improvement, which will be manifested as a PF ratio improvement within the first 24 hours, and or improvement in the other organs which might have been failing as a consequence of hypoxia.
So in what percentage of patients approximately you have to use this? Out of 100 patients?
To be absolutely honest, in the initial period when we were going through the peak, Toci was not available to us.
Okay.
And now the number of cases that we are seeing in the UK is gone down quite dramatically. Thank God for that. So therefore, and therefore we have much less number of cases, and we are using other agents which we were not able to use in the initial part, like Remdesivir. So overall, the requirement, the cytokine storm, as they keep calling it, the number of patients that we have seen with cytokine storm and ARDS, which has led to permanent reduced very significantly.
Okay, okay, thank you so much. There is one important aspect which is left is the convalescent plasma therapy. So how frequently are you using and what are the indications for which you use convalescent plasma in UK?
Dr. Anand, this
Oh,
question?
you're asking me, sorry. I got a bit distracted with the D-dimer question on there, sorry.
Okay,
So
D-dimer
convalescent
will come
plasma,
back later, yeah.
yes, that is the only other thing, I'll just say it once, the only other thing that has improved outcome is the use of an increased dose of low molecular weight heparin in these significantly ill patients. I have seen patients who were dying from just mottling of the skin and peripheries. So it is extremely important to use a higher dose of low molecular weight heparin than prophylaxis. I'm sure Dr. Juneja will agree. We can talk about that in a second. So coming back to the question of convalescent plasma, to be absolutely honest, there aren't any randomized controlled trials. I looked again today as well. However, there is evidence coming out from various studies and trials and is likely to be published soon that people who are not benefiting from the other modalities which I would want to try first, then convalescent plasma has shown some signs of helping patients. It's used as 2 bags, 1 bag given on day 1 and the second bag given either the next day or at least 12 hours apart. So there is likely to be improvement in these patients.
So what is the right time to give it?
What is the right time to give it?
Again, you have to look at the clinical parameters that the patient
Okay, Dr. Juneja, yeah.
Yeah, so we have been using plasma therapy in our hospital, and if you remember, our hospital was the first one to use plasma therapy in India. So basically, you should start thinking about plasma therapy if the patient is developing hypoxia, again not responding to steroid therapy, going into multi-organ dysfunction syndrome, and it is maximum use is in the first 14 days. So beyond 14 days, the response is going to be less effective. So if you want to use it early, use it in the first 14 days, depending upon the clinical picture. See, the concept behind plasma therapy is that you are expecting that the patient is not mounting an adequate response to this virus, and there are not enough antibodies present in his blood. So you take the preformed antibodies from a donor and you transfuse this to the patient. The problem with us is right now, we did not have a quantitative assay of immunoglobulin G. So IgG you need to test in the donor plasma. If the quantity is more than 1:640, then only the titer is effective, and it is going to be effective when you use it in a particular patient. So till now, we were doing it in a blind way. We did not have that titers with us. Now, many labs have started doing the titers. So in Max also this week only we have started, we have got a kit now and we are doing the titers. We are assessing the donor plasma. We are looking for the titers, and if the titers are there, then only it is going to be useful. So the ambiguous results which we have been seeing is just because of that, because many times adequate titer is not even present in the donor plasma which we are transfusing to our patients. So if the donor plasma has got adequate titers, it is going to be much more effective. And obviously you have to pick and choose your patients wisely.
Okay, again coming back to the same question, do you have to wait for multi-organ dysfunction to develop to give plasma,
No.
or what is the right time to use? What is the right time when we should use the plasma?
See, there are the phases. So first, if the patient starts requiring oxygen therapy, then you think of steroids. That is the first thing because it has shown to be of proven benefit. So you start the patient on steroid, but you have started the patient on steroids. You are checking for IL-6 levels. IL-6 levels are not very high. Patient is still deteriorating. Then is the time that you should think about plasma therapy. And sometimes even if the plasma IL-6 levels are also on the higher side, you have given tocilizumab. Tocilizumab is not working. So obviously in a good proportion of patients, you will see that tocilizumab is also not going to be effective. So again, that is a case for plasma therapy. we have used multiple therapies. Or if suppose if the patient is deteriorating rapidly, so you have given steroids, you have given tocilizumab, you do not have time to wait for the response of tocilizumab. Again, that is the time when you should think of plasma therapy.
Yeah, very right. That's what I wanted to say, that sometimes despite interleukin-6 level may not be high, so we may not be requiring tocilizumab, but patient's oxygen requirements are going up and patient is being shifted from high flow diesel oxygen to a CPAP to invasive ventilation. Maybe that is the right time when we can try plasma therapy.
Exactly.
So how many plasma therapies have been done and what is the outcome at your hospital?
Ma'am, actually, you must be aware that we are doing a trial along with ICMR. So we had already completed 50 patients in whom we have given plasma therapy. And beyond that, we have given around 15 to 20 patients. And till the results are out, I am not at a liberty to discuss the results of that because the results will be declared by ICMR. We have already given all our papers to ICMR and they will be the ones who will be coming out with the results. So, but if you ask me on a personal level, the results have been good enough.
Okay, they are encouraging. So we should start using them. That's what, because it's now readily available. Convalescent plasma is not a problem.
Yeah,
so at Patparganj also we've started using it. But right now it's very few number of patients and we don't know how the patients will react. But I feel that using it at a right time before patient goes into multi-organ dysfunction probably would be the right thing.
Exactly.
Thank you, Dr. Deven, for highlighting the same. There are few things left, so I will involve my faculty who's been dealing into it. So the role of, what is the role of heparin? Because D-dimer level have been quite high in most of our patients. So, and many of the patients, we have seen a prothrombotic kind of a state, like people develop cerebral infarct, there are people who develop myocardial infarction. So what is the take on this, for which I would invite Dr. Amitabh to talk about the role of low molecular weight heparin in the setting of COVID.
I think Anand would be the best person to talk about it because I had seen his video earlier and he has an extensive experience. So I think Anand should take over.
Okay. All right. He says Dr. Anand would be a better person to talk about it. So, Dr. Anand, to you, this question comes back to you. What low molecular weight heparin and what is the dose and for how long?
Yeah, so basically, as I said quickly, I think that the introduction of a higher dose of low molecular weight heparin has made a significant difference compared to how we were managing the disease in the past. And as I said to you, in the NHS, it's very hard to get a change unless there's evidence, and you won't get evidence unless you give the drug. So it was, chicken and egg story, basically. The end result of it is now there is a very significant body of opinion, but without any randomized control trial evidence, that using what I'm labeling as an intermediate dose of low molecular weight heparin is absolutely crucial to changing the outcome in COVID. So there are some mortality studies which have shown that the virus affects endothelial cells, and there is an increased number of endothelial cells in the patient's capillaries. This is in autopsy findings. And the way to that leads to a very strong, not just a cytokine storm, which we are talking about, but also a very prothrombotic state. The ways to judge that are fibrinogen levels, which we've seen are quite high in these patients. The evidence coming out from China was that they have platelet consumption, but most of the patients that we have seen actually have a high platelet count. So when you find somebody with good going COVID, now we don't wait for any evidence of increased coagulation. There was a time when we saw patients, when we were putting in an arterial line, the blood was clotting in the cannula in front of our eyes. So we've seen that. Now what we do is we initiate low molecular weight heparin. The normal dose that we normally tended to use was 40 milligrams subcutaneously once a day. So we've increased that to 40 milligrams BD once a day. This approximately equates to, because the patients in the UK are slightly larger than the Indian ones, this approximately equates to 1 to 1.1 milligrams per kilogram of low molecular weight heparin, which is divided into 2 doses ideally, but if not, then a single dose of that 1 or 1.1 milligram per kilogram per day. This has led to a significant drop in the acute kidney injury as well, because the mechanism for acute kidney injury in COVID was not just the virus acting directly on the glomerular endothelium, but also increased capillary coagulation in the glomerular endothelium and in the, basically, what's it called, the nephron. So the treatment basically is low molecular weight heparin, as I said, in an intermediate dose. How long do you give this for? We started on everybody who's coming to the intensive care unit, and also on everybody who goes to the respiratory unit. Effectively, anybody on more than 40% oxygen and suspected or confirmed COVID gets this increased regimen of low molecular weight heparin. Next question is, how long do you do it for? Initially, we were doing it only for those patients while they were in the hospital, and we had approximately 30 or 32 patients out of the 1,000 that we discharged from the hospital who came back with either strokes or with very large saddle PEs. And after a lot of discussion with hematology and a national guidance was put out, and at the moment, although this is not written in stone, we have made a policy that we are giving the low molecular weight Lexin for 6 weeks after discharge. The reason why we do that is because our patients have come back with these large emboli in a period of less than 6 weeks. And we know that some patients who've been through a lot are actually very weak and therefore likely to be immobile. So 6 weeks of that same dose is continued. The 6 weeks is calculated either from discharge from ITU or discharge from the respiratory hub, which is where we look after patients who are just before coming to intensive care. This does not apply to the ward patients.
Okay, that's quite a useful information you've given, because we've not been using post-discharge low molecular.
Yes, so because India is lagging behind compared to the UK, your disease peaks have come in about 5 or 6 weeks after we've already experienced it, maybe a little bit longer. So you are about 3 months behind us. So we've started seeing the sequelae of patients having been discharged home. You will see them later. I would suggest that we use low molecular weight heparin and leave patients on them post-op, even if it means teaching them how to give it. It's a subcutaneous injection, and a substitution with warfarin, etc., is not likely to help. Also, full heparinization is also not good, because we've seen a few patients, admittedly a few, but we've seen a few patients who've had a hemorrhagic stroke or other bleeding diathesis.
We are discharging patients on NOACs. So you're not trying NOACs in these patients, because subcutaneous injections is difficult for home.
Correct. So correct. So we wanted to discuss the use of NOACs, but our hematologists again said that there is no evidence, and there is evidence only for low molecular weight heparin, and therefore we are stuck in that bind. I would much rather use a NOAC if I can, but equally there is no evidence for NOACs being beneficial. However, the point is that you're trying to avoid a clot, and therefore I can see your point of using NOAC, which is more comfortable. You can do that in India, and I can't do that here. So we are where we are.
Okay.
I agree with you, though, in principle.
Okay, Dr. Anand, do D-dimer level correlate with the dose? Like, what D-dimer level do you think beyond which we should start? At what D-dimer level, low molecular weight heparin?
Like I said, we don't care about the D-dimer level. Anybody who is showing signs of sickness, we use it. There was a time when we used to use 3,000 as a level, but we don't use it anymore. So there are some hospitals in the UK which have classified the procoagulability as less than 3,000, 3,000 to 6,000, and 6,000 and above. So that's how they had done it. But the larger body of evidence and opinion, it's just expert opinion at the moment with hematologists, is that D-dimers are not necessarily required. Anybody with a fairly severe COVID, defined as requirement of more than 40% oxygen on a respiratory hub, in our case, or on an intensive care with either non-invasive ventilation or ventilation invasively, should get the low molecular weight heparin in an increased dose.
Practicing here, Dr. Anand, is for all our ICU patients, we are giving a prophylactic dose of LMWH. But patients who have got a D-dimer level above 2000, we are switching over to therapeutic dose. So that is what we
Full
have.
therapeutic, 1.5 per kilo.
Yeah. So
okay.
D-dimer level above 2000.
You can consider that. You can consider that. But if you see increased incidence of bleeding, you can reduce it to what I've suggested as the intermediate dose.
And which low molecular weight heparin do you use? Enoxaparin or any?
Enoxaparin. We tend to use enoxaparin. Yes.
Okay. Okay. Thank you so much. So just moving on to a few questions which are left. I think we have to discuss the role of HCQS also, since it's an Indian conference and we've been using HCQS, so we can't do a COVID conference without talking about HCQS. So do we have Dr. Chakravarti on online? Is he there? He was to discuss the role of HCQS. Dr. Chakravarti, are you there? Okay, I think he is not there. So I'll move on to Dr. Gulab Gupta. So in your practice in OPD patient, are you using steroids, Dr. Gulab Gupta? And which steroid and at what stage are you using them? Dr. Gulab Gupta, can you hear me?
Dr. Meenakshi, hello.
Hanji, sir.
Can you listen me?
Yeah, we can hear you, sir.
Actually, we have treated. My experience is very limited, and we are using steroid only after 10th days. Okay. And steroid we have used is solumedrol or the methylprednisolone. We are not using dexamethasone, and we have used only for 4 or 5 days. We want to know from Dr. Anand what is right, which they are from this. Doctor is saying in UK we use dexamethasone. Which one is choice and how long?
Dr. Anand, please, can we have your opinion?
I thought we discussed this at length, didn't we? IV methylprednisolone versus dexamethasone.
Okay, no, maybe we can repeat it. First, for outpatient, do you recommend giving steroids? That's what you need to ask.
Okay. I don't have any personal experience, unfortunately, for outpatients being an intensivist. But if we think of it systematically, I mean, I really don't want to give incorrect sort of answer because I don't have any experience. But the point is that if somebody is not unwell enough to require hospital, then I don't see the point of modulating their immune response, which is effectively what we are doing with the steroid. However, I don't have any experience.
Right, Dr. Anand, you also spoke about the Remdesivir, which you start even in not confirmed cases. These suspected cases you are writing, we can start Remdesivir.
Yes. So, but when we say suspected cases, what I mean is, by a confirmed case, I mean somebody who is tested positive on swab antigen testing. What I'm calling as a suspected case is where the treating team has a high index of suspicion that this is a COVID case. And by that, I mean that we've done some blood tests. We've seen that the patient's hypoxic. They might have some changes on the chest X-ray bilaterally, which we know is associated with COVID and unlikely to be something else. And they often have a very high polymorph to lymphocyte ratio, which means that the lymphocyte count is low. So all of those things taken together would mean that even if the antigen test comes back as negative, which it does happen in about 30% of the patients anyway, and can be higher depending on how you've done the swab. And while we are waiting for the swab, because in our setup, it can take up to 24 hours to get the result of that particular swab. So that is what I'm calling as a suspected case. In those patients, yes, you can.
Any precaution, any particular test we should conduct before starting Remdesivir? Any precaution?
Okay, so it will be the liver function test which can get altered. So it will be a good idea to have a baseline liver function test. But you would have done a full, I mean, if you're giving this to somebody, you would have done a full hematological, a full blood count and all of that anyway, isn't it? So that panel would have been done. Renal function test, liver function tests, and a full blood count and a differential.
Then we can start safely to anybody. No age group, no bar in age group.
Yeah, I don't think that there is a problem with age group. It is something that we need to worry about the liver being involved. So AST and ALT is something that we need to keep an idea on.
Yeah, it's not to be given to pregnant women. It's not to be given to children below 18. That's what they, and if the liver functions are more than 5 times the upper limit of normal, it should not be given. Yes, Dr. Shukla.
Yeah, one question to Dr. Anand. In one of the critical care conferences, they have used 20 milligrams of dexamethasone, and they found the result to be much better than your recovery stage of 6 milligram dexamethasone being used in UK. So what is your comment on that? Because they found that the intubation period was very short, ventilation was very short, and they recovered very well. So any comment upon that?
Yes, so we had this discussion as well with regards to the dose of dexamethasone. The recommendation from the Society of Critical Care Medicine is based on the surviving sepsis guidelines, where the paper that they were quoting was effectively where they had used 20 milligrams and then followed it by 10 milligrams. So that is what that particular guidance is based on. That was used in ARDS patients, not COVID patients. So that particular guideline is not actually for COVID patients. Whereas recovery has been done in COVID patients and has shown a benefit. I mean, using a higher dose of steroid like methylprednisolone, we've used 500 when we did not know that we needed to use a smaller dose. Will probably produce the same response, but cause you more problems in terms of blood sugar control and water retention with the glucocorticoids. If we know from the recovery trial data that dexamethasone 6 milligrams is enough. When I say 6 milligrams, I mentioned earlier, we're talking 6.6, which is the equivalent of 8 milligrams of dexamethasone as sulfate. And if that has shown a significant improvement, then that should be enough to, control the immunomodulation. And I would therefore say that that should be an adequate dose. I do see where you're coming from in terms of the higher dose, but that's the recommendation from the SCCM, and that has come from ARDS studies.
One more to the same thing, I just continue the same question, because methylprednisolone is short acting and immediate acting, because cytokine storms are immediate. So dexamethasone takes few days to act properly. So why you are using dexamethasone instead of methylprednisolone?
In the recovery trial, it was dexamethasone that was used and not IV methylprednisolone, because at that time when the recovery trial was started, we did not know any different, and methylprednisolone was not used often and frequently. We are talking about 2.5 months ago. That is the limitation, because the recovery trial has used dexamethasone, and therefore they cannot give a recommendation about methylprednisolone. That's all it is. If the Indian experience is that methylprednisolone is working well, then obviously you can use methylprednisolone. However, I would say that if you're using dexamethasone, it's a longer acting agent. Biological half-life is much longer, as you know yourself and you just said. So it is likely that you won't need to taper it afterwards. If you're using methylprednisolone, just remember that after using it, you'll have to taper it, because it's a short acting agent.
I think if we are done with the questions. Any other questions anybody have?
Meenakshi, I'm the last person who always asks the question.
Yes, yes,
My
please,
question
Dr. Kudita.
Dr. Anand Arora. I really thank him that he's right now coordinating from UK. And I just want to ask Dr. Anand, there was some study where they have found that there is drug interaction once you are giving this Visolone and Remdesivir. Is there any drug interaction?
Visolone is steroid basically. Yeah?
Prednisolone. Prednisolone and Remdesivir.
Dexamethasone and Remdesivir. Any drug interaction?
No, we are using it. You just I'm not aware of any significant drug interactions.
Because in Mumbai, they had a trial in Mumbai recently.
Okay.
The message from there, they are not giving both the drugs together. Rather, they are preferring methylprednisolone with the Remdesivir, if at all they are using there.
Yes, I mean, I am in touch with a fair few of my Indian colleagues from AIMS as well as UCMS, and I am aware that many of them are using methylprednisolone. I mean, all I can say is my experience of methylprednisolone, as I said earlier, was with those 2 patients with early ARDS, and both of them got dramatically better. And dexamethasone is something that we're using regularly. That's the extent of my experience, and I don't want to, guess anything else.
One more question, Dr. Shukla, one more question before.
Of course.
See, there are few doctors in this forum right now who are not working in COVID designated hospitals, whether it is government or a private setup. We are practicing at our clinic. Number one question is, at UK, all asymptomatic COVID patients, are they put in the home, this quarantine at their home, or they are all are admitted in the hospitals?
They are all at home. All asymptomatic patients stay at home and isolate at home for 14 days. 14 they don't stay in a hospital.
And what is their strategy of treatment there? Strategy, I mean, there.
Nothing. There is no treatment required. Hydration, eat and well, eat properly, paracetamol. That's it for asymptomatic patients. I know in India, and there is this tendency, because a patient's paying, they want the doctor to write some treatment. And I know that there is this tendency to write zinc supplements and vitamin C and vitamin D and whatever else. But if somebody's got normal levels of those substances, then there is no special benefit from using any of that. I mean, if you're not getting enough vitamin C anyway, then a supplementation is fine. But other than supportive management, which for any viral illness, there is no other treatment that those patients who are isolating at home get. Just paracetamol for fever. There was this doubt about whether non-steroidals were appropriate or not. Now it is clarified that non-steroidals can be used. There was this doubt whether ACE inhibitors and angiotensin receptor blockers should be used or not. And there is multiple guidance that those are fine as well. So just continue with normal treatment.
So they are isolated for 14 days.
Correct.
And till how many days they are infective? Infective for others?
The infective for others actually starts before the patient's even symptomatic. So asymptomatic people who don't even know that they're infected and now getting the disease, they can be shedding virus, and they are infective till about 7 days or 10 days post viral illness, and therefore the total period of 14 days.
So 14 days they are viral free.
They should be viral free. The antigen test can still be positive because they might have broken bits of mRNA. Remember that the antigen test is a polymerase chain reaction, which actually multiplies the mRNA in the tissue, in the sample that is being tested multiple times. Therefore, you might still be antigen positive, but not infectious.
One question.
Dr. SK.
One last.
I just wanted to know those patients who are mild in nature and at home and they're in isolation. You said that non-steroidal anti-inflammatory drugs can be given. Do you think they are beneficial? Could they delay the onset of cytokine storm? Secondly, what investigations and how frequently do you advise any investigations to those patients who are at isolation at home?
Okay. The non-steroidal is being used if paracetamol is not enough to control temperature. So it's not about cytokine storm. In the initial part, you're not getting cytokine storm. So that non-steroidal that is being used initially is only for temperature control if paracetamol is not enough. With regards to what are we monitoring, I have had this question multiple times from colleagues in India with regards to their family member being in hospital, and they're worried about whether we should take them to the hospital or not in the Indian context. The answer that I've given is, if you can get a pulse oximeter at home, and a saturation of less than 96% in somebody who normally has saturation of 9900 should trigger a hospital assessment, because hypoxia, a happy hypoxia, is something that you will not be able to clinically tell. The signs would be patients getting tired on walking. There is this thought process now that these patients who are mildly symptomatic should reduce their activity because they might be hypoxic, and by walking around you're increasing your oxygen requirement and consumption, and that might precipitate worsening of your hypoxia, leading to either the brain not getting oxygen or whatever, and therefore precipitating admission to hospital. So if I know that people are able to get a pulse oximeter from Amazon, etc. If you're able to do that, measure your oxygen saturation levels. The other thing you can do is breath holding times. If you're hypoxic, your breath holding time will reduce to less than 10 seconds. Normal is more than 15. That's an old style bedside test that we used to do, and I've used it to good effect even on ITU patients. So a value of less than 7, you should not be in home environment anyway. But a less than 10, you should be thinking about, okay, do I need to go to the hospital or not?
Any blood test?
Can I ask you one question? Last one for you.
Of course.
Tocilizumab is after giving this drug, they have found that the mortality rate was very high because of superinfection. So any comment upon that?
So as Dr. Juneja said, there is a possibility because you're using an antibody which modifies your immune response. The chances of superinfection, superadded infection are higher. So you need to measure most patients would be either intubated or on CPAP. So do checks to see whether they're infected or not. And if they are, use an appropriate amount of antibiotics. CRP can also indicate whether they're infected or not. CRP does not go up much with just the COVID virus. It goes up with a superadded bacterial infection. We also tend to do a procalcitonin level because sometimes the CRPs and white cell counts might not give you the whole picture. Procalcitonin level of less than 0.5 means that you can stop antibiotics, otherwise you need them. With regards to using it, if you're using Toci, you need to use it in that situation where steroids have not helped. And in that case, you'll have to take on the side effect of increased
mortality in the last was very high with this using of Toci.
May I add one thing? In India, before we use Tocilizumab, we do 2-3 things because in India, tuberculosis rates are quite high. So before you administer any immunomodulator, you have to rule out tuberculosis. You have to do a procal level, and you have to do cultures to rule out any infection before you put any patient on Tocilizumab. And while you are administering it, you monitor CRP, you monitor procalcitonin, and adequately cover with antibiotics while it is being administered to rule out, to suppress any kind of secondary infection which can happen in these conditions.
Do you advise any blood test at home for those who are in isolation regularly?
I wouldn't. No. If you're asymptomatic or mildly symptomatic, I have had people, because that YouTube video that I did has been seen by 2,000 people or whatever. And basically, I was asked these questions, and you would give advice over the phone the best you can. You wouldn't want to treat them from home. But people have shown me blood results and all of that. There's no point in doing all this in people who are at home. It only gives them that satisfaction, but that's all. I mean, I'm aware that practicing in India can be a little bit different and people expect it. If that is the case, then just do a full blood count and a total, a differential count, get there. If you want, get some clotting parameters done. Oxygenation parameters would be pulse oximetry if they want to buy one. And that's it, really.
What
It's
about,
only for the more.
what about chest X-ray in case they are coughing?
Sorry?
What about chest X-ray if they are coughing too much?
If they're coughing, then a chest X-ray is a very low, it is an intervention that you can do. And if you see bilateral opacities, you know that it's gone to the lung, and therefore the patient should ideally be going to the hospital.
See, ideally, a pulse oximetry at home, what we are recommended is only pulse oximetry,
Yes.
because rest of
That's
the
right.
tests, nobody is actually coming to pick up the sample. Any patient who's got a COVID positive, the blood tests are actually very difficult, and doing a chest X-ray means he has to go to the hospital because no in-house X-rays have been done. So breath holding time is what we have been telling. I've been doing a lot of video consults. So we just tell them a breath holding time and pulse oximetry and pulse rate monitoring. I think these are good enough. And any patient who is beyond this should ideally be admitted to the hospital, and all the tests should be
correct.
Dr. Anand,
I totally agree with you.
One question, very important question. In India, we are using hydroxychloroquine very frequently. To dose of like 800 milligrams per day, first day, then followed by 400 for next 4 days. It's already trial by WHO says that there's no role of this one. But this has been tried in 100 countries throughout the world. So I don't know what will be the benefit of this giving. Should we give it or not to give it? This is some $1 million question based such, but
it has been discussed enough number of times. They have not been using HCQS. In UK, they have not been. They have not been using.
But WHO
Actually,
has done trials.
actually it is not $1 million question. It is a 10 paisa question. That's why nobody is using hydroxychloroquine.
US and UK have packed for this Remdesivir now. They are not going to use any other drug besides Remdesivir.
And we've also started using Remdesivir.
But we are also not going to stop HCQ here.
We've not stopped HCQS, but we've started using Remdesivir.
I had bought some hydroxychloroquine because I knew that the NHS won't allow us to use it unless there's a trial and all that. But I have not used it. If anybody wants it, I can courier some to you.
Sure.
I would request you to use it.
I don't think so.
Charge of courier will be more than the cost of the drug.
I have intubated so many patients, and I have done percutaneous tracheostomies on more than 6 or 7, I can't remember how many, in this COVID period, and my antibody test was negative. So I must be doing something right.
So you're taking HCQS?
No, I'm not taking anything.
Okay.
Just a FFP3 mask and wash my hands.
Most of my colleagues who have developed COVID, they were not taking that.
Sorry, there's a lot of echo and I can't hear. So anybody who's not talking, can you please mute?
Okay. So in India, we've all been taking HCQS actually.
Most welcome. Carry on, sir. Carry on. Whatever you want to do is fine.
Okay. Okay. There are a few more questions which are there. I will fastly read it to you. First, Ashish, you have the chat box with you. Can you answer the questions?
So one important question is there.
Doctor,
in UK, these health workers or front warriors, they are not on any prophylactic treatment for this corona infection?
Not in UK.
If you are asking me that question, the only prophylaxis we are doing is proper PPE.
As a proper PPE, no prophylactic treatment.
No prophylactic treatment at all.
There are a few questions, Dr. Anand, if you can read from the chat box and answer. Or I will read them for you. Which one parameter can be reliably used to predict cytokine storm? Would ferritin be
yes.
marker?
Any acute phase proteins, basically ferritin is one of them. Interleukins, if you're measuring them, that's it.
Okay. So anything can be a marker, CRP, interleukin, ferritin, D-dimer. I think all these are non-specific marker which could be elevated in any of the disease. Dr. Anand, which PPE do you use when you intubate?
Okay, so again, this is changing a little bit. When we started, we were wearing a standard surgical gown or a onesie like the hazmat suits, whichever was available, because there was a problem with supplies. The point was that I don't wear my normal clothes and go inside the intensive care unit. So I wear a set of clothes, go into the hospital. In the hospital, we get a set of scrubs like standard theater scrubs, change into that like anybody would if you're going into theater or intensive care unit. Now that becomes my first layer. When I go into the intensive care unit, I wear either a surgical gown or which is a full sleeved, long sleeved gown, or wear a hazmat suit, whichever was available. We've also got some washable ones now. So whichever is available, we wear that. We used to put a set of gloves on, and then in terms of covering the face, etc., we use a FFP3 mask, and because we were going to run out of masks because the single-use ones would have been in short supply. We got some silicone masks which have a filter which lasts for about 3 to 4 months. Now these masks are actually used in the building industry and are actually not rated for viral particles. So if you use one, it should be rated for aerosol prevention as well. And Amitabh knows the mask that I was wearing because I'd sent the details to him. Basically, any mask that is an N95 mask is fine. Once you've got an appropriate mask, you need to be fit tested. There is no point wearing a mask if you're not fit tested, because you need to know that that mask is appropriately protecting you. In addition to the mask, we used to wear a hat or a surgical cap. I'm saying used to because things have changed now and we've learned, and the infection prevention control precautions now have changed. We used to do all of this, and we have had, thankfully, a very good return in that my antibodies are negative, and despite doing all those intubations and tracheostomies, I've been fine. For the specific things like tracheostomies and we also use a visor. So visor is basically like a screen across your face so that any aerosol does not come to you. When we talk about PP, remember that what we're trying to do is stop 3 methods of transmission. Number 1 is somebody coughing on you, which is aerosol. The FFP3 mask and a visor, if you are that close, will protect that. Just wearing normal spectacles does not. Number 2 is fomite transmission, which means stuff falls onto your clothes and you touch those clothes and put it into put your contaminated hand on your mouth or nose. So that is the way to protect that is the visor if there is some fomite there as well. So the visor is doing 2 things. It is doing fomite as well as aerosol, and wearing a long sleeved gown so that the inner set of clothes that you're wearing don't get affected, right? What we've realized now is that good hand washing with just soap and water is good enough, and therefore we have gone from using 2 sets of gloves to 1 set of gloves because we realized that going between patients with the first set of gloves on was leading to cross-contamination with bacteria. So yes, you're preventing COVID, but not everybody was going between ITU patients after decontaminating your gloves properly. Washing hands is better than applying gel onto gloves because gloves can have little crevices, etc., which do not get properly cleared with just using the alcohol gel. So, we have now shampooing every day. So head protection is completely optional if you want to use it or not. Visor is required when you're in close range to a patient and also when you're doing aerosol generation, but we don't wear a visor when we go into an intensive care unit when you're not going to be very close to the patient. FFP3 mask, which is the same as your N95 mask, which is properly fit tested, is a must even in suspected patients, because as I said to you, people could be shedding virus when they don't even know themselves and they're asymptomatic still. So my rule of thumb is if I have to go to an area to examine a patient in the accident and emergency on a ward, even if it is a COVID negative ward, our hospital has got COVID positive and negative wards, I use my FFP3 mask at all times when I'm interacting with a patient at close range. So we've talked about that. So the things we've changed now is instead of double gloving, we just wear a single pair of gloves. and that is taken off and the hands are washed between patients to reduce the chances of cross-contamination between patients. Does that answer your questions?
Thank you, Dr. Anand. I think you've answered most of our questions, and I intensely thank you on behalf
not
of
at all.
API
It's a
Noida.
pleasure. It's my pleasure and my honor.
Okay. So it was nice to have you, and we could share your experience. And actually, you managed to answer most of the queries, and you managed to stay through the whole CME. So actually, lots of thanks to you. And I wish to connect to you again once more, maybe after 15-20 days, and we will engage you once more to have.
There's somebody here. There's somebody here who's asked a question. Emergency, is it okay? I wouldn't use an oxygen cylinder at home because you are delaying going to hospital and the added benefits that come from being in hospital. I know circumstances are difficult or different in India. So if you want to use an oxygen cylinder only as a temporizing measure while you get to a hospital, that's fine. But I wouldn't recommend having an oxygen cylinder at home to treat somebody. If you need oxygen, if you are hypoxic, then you need to go to the hospital. I'm sorry.
It's not only oxygen which is deficient. There are other things also,
right.
as you've said, cytokines
Yeah, there's
and
so
other
many
things.
things.
So
There's
if
so
the
many
disease
things we
is
don't.
if disease is that severe that you require oxygen, that means you need to be in the hospital.
You should be in the hospital because you can deteriorate very rapidly.
Yeah. So if there is a drop in oxygen saturation, please visit the hospital.
Correct.
Okay, I think there is any test to know whether the patient is contagious after recovery.
No.
Once the COVID PCR is negative, is there any chances of reinfection?
Okay, so there was this doubt that people were getting reinfected, and that came from the South Korean studies because they were doing a lot of testing and tracing and antibody testing. But the evidence that had been suspected from those South Korean studies has been by themselves. They have clarified that it was, they were testing it incorrectly. And at the moment, there is no known case of reinfection. There is some doubt that the antibody response does not last for more than either 2 months or 6 months. We're not sure yet. And if that is the case, and if COVID is still here in 6 months' time, there is a possibility you might get reinfected. So even if somebody's antibody positive, the instructions are that you have to still continue to behave as if you can get it. But there is no medical evidence yet that you can be reinfected while you got an antibodies.
So how long the antibody would last, we don't know as yet. So
we don't know. Some studies are saying 2 months, some saying 6. We haven't been in this crisis long enough to know.
So we'll continue to take universal precautions.
Yes.
I think it's time to end our session. So once more, I thank you, Dr. Anand. I thank Dr. Deven, and I thank Dr. Ashish Jain, who had to leave. And I would thank all the participants. There was a huge attendance. I think there were around 60 people who joined on this chat group. So I would like to thank all of you. And if there is any questions from Dr. Anand, I would take a liberty on your behalf. They can send the questions to us, and then we can text the questions to you.
My pleasure. It's been an honor, and my intention is that everybody learns from the mistakes that we committed and we've learned along the way. And if we can share knowledge and therefore, reduce the chances that people suffer, then that's the objective. And I think Meenakshi and Amitav have organized this, and that objective should be, I think, well served by this meeting.
Yeah, thank you. And it's fortunate for India that the disease came little later. So we have experiences of you people to guide us. So
yes.
Thank you once again. Thank you for joining.
Thanks, guys.
Okay, let's be
safe.